This is our final group case study project. It is on ectopic pregnancies by Kaylee, Tani, Tao, and I, Sulema. Ectopic pregnancies can be fatal if not found in time or not resolved in a timely manner. Ectopic pregnancy is when there is no intrauterine gestational sac demonstrated in the endometrial canal on ultrasound. There are different types of ectopic pregnancies, and in most cases, surgical intervention is needed. The most common location is in the ampulla of the fallopian tube. Patients usually present with pelvic pain and amenorrhea. What is a IUP? IUP stands for intrauterine pregnancy. It is defined as a gestational sac that contains either a yolk sac or a fetal pole that is found in the endometrium of the uterus. What is an ectopic pregnancy? An ectopic pregnancy is when a fertilized egg begins to grow outside the uterus. If an IUP cannot be definitely demonstrated, it is considered ectopic. The fertilized egg cannot survive outside the uterus. If left to grow, it may damage nearby organs and can cause life-threatening loss of blood. In this image, we can see the different types of ectopic pregnancies. The most common will be the ampullary one, but it can also happen in the cervix, in the intramural, in the abdomen, in the ovary, in the corneal. So this is a really good picture to show you all the locations that can happen. Some facts about ectopic pregnancy. 90% of ectopic pregnancies occur in the fallopian tube. Heterotopic and twin ectopic pregnancies are a rare manifestation. On the left image, you can see a heterotopic pregnancy. One of the pregnancies is inside the uterus and the other one is outside the uterus. The image on the right, you can see there is no pregnancy in the uterus and there is 3 pregnancies outside in the anexa. Facts continue. An estimated of 1 to 40 pregnancies, 25 cases for 1,000 pregnancies result in ectopic pregnancies. Any woman with functioning ovaries from menarche to menopause can potentially have an ectopic pregnancy. It occurs in women of all ages, often with a history of infertility, usually secondary to prior tubal damage, often results in rupture of maternal vessels at week 8 into gestational sac.
Hi, this is Tao. I will be going over the risk factors for ectopic pregnancies, some relevant information, the patient information, and the summary of the physician report. The risk factors for ectopic pregnancies are previous ectopic pregnancy, prior fallopian tube surgery, previous pelvic or abdominal surgery, certain sexually transmitted infections, pelvic inflammatory disease, endometriosis, cigarette smoking, if you're older than 35 years old, history of infertility, and the use of assisted reproductive technology such as in vitro fertilization or IVF. If you notice on the pie chart, the highest risk factor is pelvic inflammatory disease, PID. Here are the relevant information in regards to ectopic pregnancies. Patients may experience low-grade pain in the pelvis and 6 weeks of amenorrhea. In this particular case study, the medical or family history and lab results are unknown. However, it is useful to know a quantitative beta HCG prior to scanning. Levels of less than 2,000 IU, a normal early pregnancy, may not be visible. Serum beta HCG levels tend to increase at a slower rate. Rarely the urinary and or serum beta HCG will be negative despite an ectopic pregnancy. Serum progesterone levels are generally lower in a non-viable, including ectopic pregnancy. A pelvic OB ultrasound was ordered for this particular patient. This patient in this particular case study was 22 years old. This was her first pregnancy. She came in with a low-grade pain in her pelvis area with 6 weeks of amenorrhea. The summary of the physician report included the following. An empty endometrial cavity was demonstrated. Extrauterine left adnexal mass. Mass containing gestational sac with yolk sac and a single embryo with cardiac activity. The crown rump length measured 23.1, which is 9 weeks and 0 days. Normal appearance of both ovaries, and mild anechoic free fluid in the posterior cul-de-sac.
Hello, this is Tawny, and I'm going to be covering the sonographic appearance, treatment, and differential diagnosis slides. On the current slide, we're looking at sonographic images of ectopic pregnancies. Generally, you may see some free fluid or possibly an adnexal mass. Sonographic appearance of ectopic pregnancy. In the uterus, we may see an empty uterine cavity or no evidence of an IUP, pseudogestational sac or decidual cyst. There could be a decidual cast. You might just see thick echogenic endometrium. If the ectopic happens to be in the tube or ovary, you may see a simple adnexal cyst or a complex extra adnexal cyst or mass. Could be solid hyperechoic mass. May see the tubal ring sign or ring of fire sign with the color Doppler. You may also find a live extrauterine pregnancy. In the peritoneal cavity, there may be some free fluid or hemoperitoneum in the pouch of Douglas. Also free fluid in the hepatorenal recess. Treatment of an ectopic. Sadly, the fertilized egg cannot be developed outside of the uterus. Therefore, the ectopic tissue must be removed in order to prevent any life-threatening conditions. In case of an early ectopic pregnancy, the medication methotrexate is used. That will inhibit the cell growth and dissolve cells. But the diagnosis must be certain before giving that treatment. Another HCG test will be ordered after the injection to determine if the treatment is working. Salpingostomy is when the ectopic pregnancy is removed and the tube is left. Salpingectomy, we're going to remove the ectopic pregnancy and the tube. In emergency surgery, if the patient has heavy bleeding, emergency surgery may be necessary. In some cases, the fallopian tube can be saved. However, a ruptured tube must be removed. Differential diagnosis. Ectopic pregnancies could easily look like any number of other pathologies due to the fact that only 50% of patients present with pain, amenorrhea, and vaginal bleeding. The pathologies that ectopic could mimic are appendicitis, salpingitis, ruptured corpus luteal cyst or ovarian follicle, spontaneous abortion or threatened abortion, ovarian torsion, or urinary tract disease. Along with those, there are other differential diagnoses that ectopic pregnancies may appear as. such as abortion complications, cervical cancer, dysmenorrhea, early pregnancy loss, hemorrhagic shock, hypovolemic shock, or placenta previa.
This slide shows us how to determine a corpus luteum from an ectopic pregnancy. A small round echogenic donut appearing adnexal mass with the typical features of an unruptured tubal ectopic can be seen. The key task in the diagnosis is then to determine whether the mass is within the tube and separate from the ovary, or whether it is a corpus luteum and part of the ovary. Dynamic intermittent probe pressure is key to sonographic assessment in this case and allows proceedings with definitive management. So in order to differentiate the two, probe pressure is used to see if the two rounded structures move independently, sliding past each other, or whether they move together as one, indicating they are both likely to originate from the ovary. This slide shows us how to. In conclusion, ultrasound imaging was used on a 22-year-old female with low-grade pain in pelvic area and 6-week amenorrhea. In her ultrasound, it was discovered that her pregnancy was growing outside the uterus. The pregnancy was growing in the left adnexa, and ectopic pregnancy can become extremely dangerous if not resolved in a timely manner. Unfortunately, the pregnancy was to be removed to prevent life-threatening conditions to the mother. Ultrasound is an amazing modality that aids in the evaluation and diagnosis of ectopic pregnancies. It is important to know what to look for and evaluate when performing an exam where an ectopic pregnancy can occur.